is not going to be here. Bonnie Hartstein. Here. Charles Jaquith.
Here.
Juan Juarez.
Here.
Julie Lewis.
Here.
Sally Snow.
Here.
Thank you. Jorge Sainz. And Vern Walker.
Here.
Now, Deb, did I? Okay, there we go. All right. So, as we start every PED subcommittee meeting, we start with our committee liaison reports. We've got Air Medical. Jorge is not here, so we will defer that one. EMS, Vern Walker.
The EMS committee met yesterday, and there were no pediatric.
Is it on?
Just get it closer.
The EMS committee met yesterday, and there were no specific pediatric issues discussed.
Education, Charles.
The Education Committee meets this afternoon. In their in-between meeting, they were still discussing transition courses and stuff, but there was nothing really that was pediatric related.
Injury prevention, Deb Brown.
They were canceled.
Oh. Let's come back to Deb for last meeting. Yeah, I saw today's meeting, or this session meeting is canceled. Juan Juarez, Medical Director.
The medical directors met yesterday. Really no pediatric issues, with the exception of some updates. Dr. Morber updated the pandemic and catastrophic events. The pediatric aspect of that would be how to allocate resources specifically for ventilators. Should we have a statewide pandemic, which looks like to be at the highest level of a look for the state. There's approximately 6,000 ventilators in the whole state, and how can you disperse these amongst all the necessary patients? They looked at looking at Utah's field triage questions, and what they found for pediatric was it wasn't suitable in the current form to be utilized for our pediatric populations, and so they were going to go more in depth into that. They were looking to make the key to their triage be local and regionalized as opposed to a state level of standardization. The other issue for pediatrics possibly would be a look at the current freestanding emergency centers and how EMS responds or takes from the field to a dedicated ER hospital system versus the freestanding, and there's some issues in terms of what it means to be licensed. Once you are licensed, however, you should have the full capacity to receive patients, and that may have a bearing for pediatrics as well. Outside of that, there are no other issues.
Great, thank you. Stroke, Julie.
The stroke meeting was 9 o'clock this morning, so that just got out. Nothing pertinent to pediatrics, but there was a couple of really interesting survey and data presentations, one from CTRAC, and if you want to see that, you can go to their website at ctrac.org to see that information. There was a Dallas grant presentation also this morning. I don't have any information on where you can find that. And then also a dishes report for their survey from 2011 for stroke and cardiac data, and I think the committee decided to make that public, so I'm sure that will be coming out soon. And then lastly, Dishes also said that they will accept either certification for Joint Commission or the DNV for stroke, comprehensive stroke centers. So the applications will be up by September 1st, and they'll be accepting the applications October 1st.
Great, thank you. Trauma systems, Sally.
Trauma Systems met yesterday afternoon. They continue to review recommendations for changes to Rule 157 for the designation criteria for Level 3 and 4 centers. The TTCF and the TTAF Trauma Division have collaborated to try to pull together the list of recommendations, and there was a discussion that took place and consensus reached on the recommendations that were presented. There were a few recommendations made for changes to the standards and events, and those were reviewed as well. There was a discussion about the definition of trauma CME. There was a recommendation made to consider a statement, perhaps in the rules, maybe not, that would help trauma coordinators decide what education qualifies as trauma. The list might include but not be limited to trauma injury, shock management, airway management, disaster management, and trauma systems development, and those would all qualify as trauma CME. There was a discussion about the Trauma Registry. Apparently there was a group of stakeholders who met with the registry officials or staff yesterday morning to address some concerns that the stakeholder group had, and the consensus was the presentation ended up that the stakeholders were satisfied that things were going okay, and they were going to support moving forward, and that sounded like it ended up very positive. There was a discussion about registry validation. Jane talked a little bit about a potential plan for involving the RACs in validation of registry data. This plan is in early discussion phase, and no plans are definite. I talked a little bit about the fact that the Emergency Nurses Association has decided to pull the TNCC re-verification course, which is a one-day course where nurses who are current in TNCC can take a one-day course and re-verify. The ANCC, which is the body that accredits CE for nursing, has said that they will not allow organizations to provide CE unless the content of the material has changed at least 50%. So ENA's board made a decision to not do re-verification courses anymore. So after December 31st, 2012, there will be no TNCC re-verification. So if you want to do one, you better get it done before December 31st. There was a lot of concern expressed on the state chair's conference call last week. It was ENA's opinion that the reason nurses take courses is for the CE. And those of us in the trauma business reminded them that no, they take them because they have to stay at a verified provider. So if anything changes about that December 31st deadline, I'll be sure and let people know. It was not a comfortable conversation.
Can I ask a question?
Yeah.
So it was because the ANCC didn't re-accredit them for providing CME or CE?
No. They just said that you can't do a re-verification and give CE on a course that has not changed. Apparently, the American Heart Association has already made that stand on things like ACLS and BLS and stuff like that. So, no, it's just, and ENA's commitment was to make sure that they stay on the very strict every 4-year revision timeline, so that when it comes time to retake TNCC, it will be new material, and you'll have to take the whole course. So that's all my report.
Thanks, Sally. The RAC report, that's Britt, so we will defer that, and then disaster planning, Bonnie.
Hi. You hear me, right? So two topics that have come up in disaster planning that I think affect the pediatric community. One was the development of this National Health Security Card, which was a kind of a concept phase. It was an early part of this year in April or so. They had a meeting in San Antonio, and this was a card that would be carried by individuals who would have up to 30 data points regarding their past medical history. And I've been in communication with Eric Epley through an email, expressing interest in this for the pediatric community, for kids with multiple medical problems, et cetera. Unfortunately, due to lack of funding, it's not right now being implemented, but it's far along in the concept phase, so it could be. So that, I think that's a good move forward for some of our kids, if they were able to participate in this. Another topic that has come up is the transportation or evacuation of children both from hospitals or to hospitals during disasters. They've fielded these buses, which are ambulance buses that are able of transferring up to 20 patients during disasters or evacuating hospitals. In discussion of the pediatric implementations of these evacuations, the committee has paid attention to the needs of the kids and have communicated with 2 hospitals in San Antonio as well as Texas Children's to discuss the use of isolettes in these buses. So it's thought that there are some logistical considerations, like whether the isolettes could be strapped to a stretcher, whether they would be staffed effectively by the neonatologist who might need to accompany. And I guess the bottom line is they're capable of taking isolettes in the right circumstance, but it would be better to move mostly the well babies if they weren't able to be evacuated. It's a better platform for that, but it's possible to transport neonates, sick neonates. Also, along those lines, children, they are stocked with pediatric equipment. Again, better to transport less sick kids. I guess the concept is during an evacuation, they would have an ambulance accompanying the bus in case one of the passengers got sicker and had to be transported to more urgently or have one-on-one care. So there have been a fair amount of considerations made for the pediatric population in these AM buses. So that's interesting. Dudley Waite was very good in communicating with me and said he would be available if we had more questions regarding this.
Great, thank you. So we move on to our next agenda item, which is an update on the child fatality review teams. Susan? I don't see her. And I didn't receive a final confirmation, so that takes us to, and we'll table that, agenda item number 3, which is a position paper on minimizing radiation exposure in the pediatric patient population. Before we start with the exact discussion on our position paper, I wanted to introduce Jerry Cogburn, who is with the Environmental and Consumer Safety section of the Texas Department of State Health Services. Do you want to tell us a little bit about Image Gently and what your group specifically does?
I work for the Department of State Health Services in the Division of Regulatory Services for the inspection branch. The radiation program consists of 3 branches. The licensing branch that licenses the use of medical X-ray equipment, or it actually licenses all uses of ionizing radiation. The inspections, or the radiation inspections branch, we inspect the X-ray machines against the standards that we produce. And then there's policy, quality, and standards who write the regulations that establish the standards.
Great. So we would certainly appreciate any of your feedback as we go through the in-depth discussion of our position paper. So just to give everyone a little background on this, we created a policy statement in our last meeting with critical points of discussion. We had segments that were distributed. We've asked members of the group to bring those back with their comments so that we could also incorporate public statement as we review this policy paper that we, or position paper that we hope to take to the big GETAC meeting tomorrow to endorse. So all of that was distributed ahead of time, so if you've had the opportunity to go online and download that, you'll have that in front of you. But I'm just going to read through segments of this, ask for comment, and we'll move on to each segment, vote at the end for adopting this as a policy statement. So this statement was created in 2012 by the Pediatric Subcommittee of the Governor's EMS and Trauma Advisory Committee, GETAC, and reflects the opinion of GETAC. That's how it starts. For background, computed tomography has proven to be a remarkable tool for improving the diagnostic accuracy of the clinician treating children with illness or injury. Its utility has seen a significant increase over the past 2 decades despite no proportional increases in severity of illness or injury. However, the increasing use of CT has potentially adverse effects on the growing child susceptible to radiation-induced malignancies, including the development of fatal malignancy in an estimated 500 patients per every 600,000 abdominal and head CTs performed in children under 5 years of age. With over 175,000 children and young adults, one recent cohort study revealed a threefold increase in the risk of brain tumors and leukemia following a cumulative absorbed dose to the head or bone marrow, and it gives specific settings. Estimated this would equate to 1 case of leukemia and 1 case of brain tumor for every 10,000 CT studies performed on children 10 years and younger occurring in the first decade of life following the first CT study. Any comments on the background? Is that sufficient to address need, potential scope of danger, and the risk of ionizing radiation? Okay. Next segment, although CT imaging may not be avoidable, the amount of radiation delivered can be reduced without detrimentally affecting study results. Development of low-dose pediatric-specific protocols has been advocated by the AAP and the American Pediatric Surgical Association in statement papers that support adherence to the principles of using radiation as low as reasonably achievable, ALARA, for CT imaging. Easy-to-follow protocols are readily available. The Alliance of Radiation Safety in Pediatric Imaging, and we have a website link there, offers an online resource for healthcare professionals and technologists with step-by-step guide to developing low-dose protocols. Providers and institutions that care for children should evaluate their CT scanners and institute protocols to reduce radiation emissions. Any comments on that segment? Do we have any concerns for the recommendation that CT delivery of radiation should address specific pediatric needs? Is that statement strong enough? Okay. Next segment, the design of protocols and guidelines in the evaluation of the pediatric patient has evolved as diagnostic modalities have developed. What was once perceived as a unique, goal-directed clinical evaluation of the pediatric patient fraught with risk has become a diagnostic imaging goldmine for the clinician to evaluate for the presence of illness or traumatic injury. Many of these protocols are based on adult literature and experience because the cohort of pediatric trauma patients in many studies are small. Facility trauma designation has also been tied to the adherence to trauma protocols, many of which include evaluation from the top of the head to the upper thigh via CT. These protocols often do not take into account the overlap of radiation that occurs as separate studies are ordered, the severity of trauma, the need for reduced radiation for the pediatric patient, or age-based injury patterns. For example, the incidence of pediatric cervical spine injuries is approximately 1/3 that of adults. Any concerns for the way that we've stated the unique needs of children, the tie into the science of care delivery? Please recognize that the statement that is implicit in this is that we call into question the application of adult-based protocols to pediatric patients. Okay. So on to the next segment, which I just lost. Okay. Clinical decision rules? Yeah. Clinical decision rules derived from evidence-based best practice can assist the clinician in determining the need for radiographic imaging of the pediatric patient with illness or injury, stratification of the severity of the patient, and identification of risk associated with clinical and/or laboratory predictors can improve diagnostic accuracy and help minimize the need for evaluation via CT. For example, clinical decision rules can minimize the need for CT in the evaluation of children with suspected appendicitis. Utilization of clinical and laboratory scoring tools can define those at both high risk and low risk for appendicitis, thus limiting more extensive radiographic evaluation to those with equivocal findings. Moreover, ultrasound, a safer modality for radiographic evaluation, has been utilized with high sensitivity and specificity for detecting appendicitis in children, thus obviating the need for ionizing radiation from CT studies and can be a more cost-effective strategy. A thorough history and physical examination combined with the appropriate clinical decision rules should dictate the necessity of the correct imaging modalities warranted in pediatric patients cared for in emergent care settings. Any comments on this segment? Keep in mind that what we are encouraging here is an effective and efficient evidence-based approach to applying science to care delivery, using clinical decision rules as much as possible. So a lot of conversation may evolve from this regarding the application of evidence-based guidelines and protocols. Okay. Next segment, the transfer of the traumatic pediatric patient from a rural or referral hospital to a level 1 trauma center has been proven to reduce mortality in the severely injured patient, as CT studies have become highly utilized as the primary diagnostic tool in the evaluation of the traumatic patient. Repeat imaging among institutions is a major source of overutilization and exposes patients to unnecessary cost and radiation while not significantly altering outcomes. CT studies formed prior to transfer to a level 1 trauma center lead to a variety of quality of care issues, including duplication of studies, increased cost, increased radiation exposure, possible increased radioactive dye exposure with contrast-induced nephropathy, increased length of stay, and increased mortality and morbidity. Retrospective studies have noted that repetition of CT studies after transfer to a trauma center vary by body part imaged with repeat frequencies between 4% and 90%. Multiple institution-specific factors have been identified as reasons for repeating CT studies, with incompatibility of CD or lack of availability of digital images having the highest frequency. Importing outside images to PACS appears to reduce the rate of repeat imaging at the transfer of care between institutions. Studies have shown up to a 17% decrease in subsequent 24-hour imaging utilization for patients whose CD imports were successful to the PACS system. Receiving institutions can avoid repeating scans unless there are technical problems with image quality, lack of compatibility, no images sent by digital media, lack of appropriate scans for diagnosis, or need to assess a changing clinical picture. Moreover, in the current era of electronic exchange of information, regionalized trauma systems can adopt more efficient and reliable means of electronic transmission of medical records and images. Advances in these areas have potential to reduce morbidity and mortality by expediting transfers, reducing radiation and intravenous contrast exposure, and improving healthcare costs. The current standard of scanning CDs into PACS systems could ultimately transition to cloud-based technology. So, any changes to this paragraph? Are we confident that the underlying or theoretical underpinnings of this is that we are encouraging institutions to have better collaboration amongst transfer to improve their cloud capabilities
There's just a little portion here that's kind of redundant. I don't know if we need to
Okay.
wordsmith it. This
Sure.
receiving institutions can avoid repeating scans unless there are technical problems.
Yeah.
There's a sentence about receiving institutions can avoid repeating scans, and it's got a list of reasons why you would have to repeat the scan, which just sort of, to me, is intuitive. I mean, if there's no lack of appropriate scan, no images sent, of course you're going to have to repeat it. Do we need to say that?
So, would we agree then that we are comfortable with removing the reasons for repeating scans and leave it simply as receiving institutions can avoid repeating scans?
Yeah, I mean, that would be that's my suggestion.
Okay.
Take off.
Everyone comfortable with that? That's an easy edit. Okay, so we end then with the committee therefore recommends the following, and we'll stop with each one and take comment. Number 1, all CT scans on children should be performed using pediatric dose reduction protocols. Pediatric protocols are available through the Alliance for Radiation Safety in Pediatric Imaging. Are we comfortable with that recommendation?
Do you want to put the website on there? Or is that...
It's above.
Okay.
Number 2, avoidance of the use of protocols which automatically results in the performance of multiple CT studies, head, cervical spine, chest, and abdomen and pelvis in pediatric trauma patients. So this is really a paradigm shift. We're asking institutions not to automatically implement protocols that may be sitting in triage for their patients. We're comfortable with this. Number 3, imaging modalities that do not use ionizing radiation, such as ultrasound, should be used when feasible. Are we comfortable with that? That seems to be the most benign. Okay. Number 4, understanding and linking guidelines of care that utilize evidence-based practice strategies will help minimize the use of unnecessary testing. Again, for many institutions, this is going to be a paradigm shift in encouraging either the adoption of evidence-based protocols or the creation of their own. Are we comfortable with this? Number 5, avoidance of further CT imaging once the decision to transfer to definitive care is made, unless the accepting institution specifically requests a scan prior to transfer. If CT imaging is performed prior to transfer, the images should be included in the transfer documentation on disk or some other form of reviewable file. The final radiology report should be forwarded to the receiving facility as soon as possible. Acquisition of radiographic testing or delaying testing should be balanced against the risk of delaying critical care for stabilization of the ill or injured pediatric patient. Are we comfortable with this? I envision that for many, this means a checklist at transfer. All right. Number 6, and we are coming into the information age here. Accepting institutions should avoid repeating scans. Consider access to a cloud-based digital image translator. Okay. Great. Any comments?
I would just make that other comment. I mean, I know that the website is listed earlier, but if you were doing this quickly and just went to the findings, kind of like in a radiographic report where you just go to the findings at the end, you might want to include that website so someone could just find it and not disregard
Okay.
because they don't know where to find it, you know, might restate it.
All right. I will cut and paste, or
So
copy
that
and
would be
paste.
best.
And that being said then, all the references are included. Any public comment that we need to address? Mr. Cogburn, anything that you would add?
The only thing that I would just for your information tell you that we currently have rules on the Texas Register in the final stage of comment. And in those rules, we've incorporated a radiation protocol committee requirement. And through the rules, we're going to require facilities to establish these committees, and basically we expect them to cover what you just described here in your position statement. So I think it's going to fold in very well with your position statement.
Great, wonderful. So just as an adjunct to the, well, I guess we need a final vote then. So given the changes that we've made, do I hear any motion to move this forward as for endorsement by GETAC? Okay, anyone second? Everyone in favor? Anyone against? And it looks like this goes to GETAC tomorrow then. Great, thank you all for your incredibly hard work. This was all piecemeal with a number of different segments, so thank you guys for that. I do want to say that these sorts of guidelines and policies often take years in the world of policy implementation to adopt unless they have a bite behind them. And so it's nice to hear that. But in addition to that, I think the dissemination of this kind of knowledge is well partnered with intervention strategies. I know that the Radiology College, as well as the American Academy of Pediatrics, through the section of emergency medicine, are working on a 2013 rollout of a form of an Image Gently program. So it's my hope that we can readdress this as a provision of intervention strategies, perhaps not in this next meeting since we need follow-up on GTAC's proposal, but on the meeting after, and begin talking about ways that we can create best practices for institutions to take this on.
So Dr. Macias, this is a great document. I think it's long overdue, and I know there are other states that have done the same thing. Thoughts on getting this distributed out to, because if you're from a pediatric institution, you sort of don't need this. Hopefully you're doing this already. It's the adult institutions, the rural institutions that do not see children as often that need this information. Any thoughts on how to get this information out to them?
Well, that was actually what was part of the dissemination plan discussion. So I think that there are a variety of societies that we can partner with across the state. Nursing, physician, respiratory care, radiology technicians, radiologists. There are the EMSC state partnership and their aggregated partners. So my hope was that at our subsequent meetings, we'd come up, number one, with a dissemination strategy, but really also to come up with some tools, perhaps even the equivalent of a safety surgical checklist that might help institutions understand where in the process of addressing these pediatric issues. And I make the point that in many ways, we are likely going to be the only champions because these kinds of radiation risks to cancer malignancies and cancer deaths are not seen in the adult population. These are based on the rapid growth of children and therefore a very unique pediatric problem as opposed to the adult population. So it's really going to be incumbent on us to see this as completely our responsibility to do. So if I could ask you to do some brainstorming in professional societies that might work with us to disseminate this, tools that we might create, we can bring this subject up, and when we come for our next session, we'll start populating the matrix of potential areas and potential tools, and then hopefully work with our professional societies to include TPS to disseminate some of this. Great. So, that being said, and we are right on time, EMS for Children State Partnership Update. Tony Gilchrist and Manish Shah.
Good morning, Tony Gilchrist, EMSC. We, over the last year, did a couple of surveys. We wanted to highlight some of the results from these surveys. We're going to do this pretty quickly so we can answer some questions hopefully at the end. But these surveys, the Texas Medical Director Survey was a survey of all the medical directors for the 911 services in the state. And the provider's perspective was a convenient sample survey from the last year's EMS conference. And so basically this was built on our 2010 surveys, which showed a significant gap in access to online medical direction with pediatric patients, and also the EMS agency's interest in having pediatric protocols provided, or at least some help in getting pediatric protocols, and their interest in having some form of online medical control available from pediatric base stations, at regional children's hospitals. And so we wanted to dig a little deeper into some causes, and I'm going to skip right on through most of this. I guess I should tell you a little bit about what we got. Our EMS provider survey was a very small, convenient sample survey. We had 84 surveys that we analyzed. The the medical director survey, however, we sent invitations to all the 911 responding medical directors out there, and we analyzed 40% of them. So not a great response, but certainly a pretty good average. What we got there, this is the average monthly call volume for all the agencies, just a little over 1,700. You'll see the median is about 400. And from that, that generates, in the urban area, 51 calls a month on average for medical advice other than routine notification, hey, we're coming to the hospital. In the rural area, that's about half of that. And that's for all patients. And from that, we get, in the urban area, about the average, and this comes from the medical director's survey, the average number of pediatric calls for medical control are 12 in the urban areas, with the median being just over 2. And you'll see in the rural area, it's about a third of that, with an average of 4 calls per month. Many of the medical directors made a note that I may get 1 call a month. So even though, especially in the rural area, the calls for pediatric online medical direction are relatively rare, what we found was that they make up 21% of all calls for online medical control, which is disproportionately larger than the number of pediatric transports, which literature shows is about 10%. And so certainly folks out there, when they have pediatric patients, are calling for medical advice. We also knew that there were problems in getting in touch with medical control for one reason or another. And so we wanted to find out a little bit more about that. And these are the 2 most common reasons reported. And you can see there was a lot of agreement between the EMS providers and the medical directors. Number one cause, obviously, something that is not unexpected: poor radio reception, poor cell phone reception, and you can imagine this is probably more common in the much more common in the rural and frontier areas. That's a difficult problem to deal with, technological infrastructure. But you'll notice that both of the surveys, number 2 answer was, when we do get through, nobody answers the phone or there's no physician available. That's a problem that we can address. And so I thought that was a significant finding. We also asked, what is your primary source of online medical control? The EMS providers reported that 55% of the time that their medical director or designee is the primary source. 45% of the time it's somebody else. And you can see that most of that 45% was split between I call the hospital where I'm transporting to, or I have a designated hospital that I call regardless of where I transport to. Medical directors, 69% of them reported that they do their own medical direction, leaving the other 31% to somebody else. And so we wanted to know, when somebody else does do your medical direction, what do we know about them? The medical directors reported 49% reported that they don't really know about the training of the physician that provides medical direction. 43% reported that medical control physician probably won't know their written protocols for their agency. Only 14% felt that the provider, the physician providing medical control really wouldn't know the training or the skill level of EMS providers. But I thought this was interesting. At the end, 80% reported that they receive no QA/QI from whoever it is that does online medical control for their agency. And so we asked the EMS providers, have they received online orders that contradict their written protocol? And 13% of the time they said yes. Another 11% of the time they said, I don't know. And that was a little eye-opening. And if there's ever, if there's ever any question as to whether or not online medical direction is needed, think about, in 2010, there were over 300,000 pediatric transports. 11%, I don't know if what my protocols are. And that's a lot of extrapolation from that, but you get the idea that there's some gaps to be filled there. We also wanted to get the medical director's perspective. If you recall, in 2010, the EMS agency said, hey, we would like to have some help with our pediatric protocols, and we would like to have access to online medical direction. And so we asked the medical directors their thoughts. 79% agreed that standardized, evidence-based regional pediatric protocols would improve the quality of care. 73% agreed that pediatric online medical control from a PEM specialist has the potential to improve quality. 72% said that they would consider utilizing medical control from a base station at a regional pediatric center. And 82% are interested in EMSC-created evidence-based protocols. And so to dig a little bit deeper, we asked about, and this comes from some of the communications we had since our last surveys with medical directors, with other stakeholders, and these are some barriers that had come up in conversation, so we just asked in the survey. And 63% felt that varied protocols within a given region would be a significant barrier to having regionalized online medical control. And 59% stated that varied EMS provider certification or scopes of practice within a given region might be a significant barrier as well. So those are some areas that we need to address. Certainly there were some limitations to our surveys, especially in the EMS provider survey, very limited sample size there, and some selection bias. It was interesting to me that overwhelmingly the number of providers that came to our booth were ALS, considering that the ALS providers are a minority in the state, between ALS and BLS, so that was interesting. But 37% of our surveys for the medical directors were missing monthly online volumes. They just didn't know. So some limitations there. Bottom line is that there are common barriers there, the poor cell phone and radio reception, a difficult problem to tackle perhaps, but the other one is no answer to a call or no physician available when they do call. That's certainly something that we can improve. Someone other than the medical director or designated physician is frequently the expected resource. Pediatric online medical control utilization is disproportionately higher than transports, which is consistent with literature about the comfort level of EMTs taking care of kids. Calls for pediatric online medical control in a rural setting are rare, and standardized evidence-based regional pediatric protocols and base stations are strongly supported by medical directors. And so our next steps continue to develop pediatric protocol resource with evidence-based literature summaries and guidelines for the use and creation of more standardized local and regional evidence-based pediatric protocols, and to continue to work with all the stakeholders, medical directors, EMS agencies, children's hospitals, and community hospitals to enhance current online medical control communication infrastructure. And so that is a quick synopsis of our survey, and I'll take any questions.
Very nice work, Tony.
Tony, did you have any sense of when they filled out the questionnaire in the negative as to if they thought it was a good idea to have online medical control or regional PIM position, the ones that were responded no, the 5 to about 11%, I saw the 3 numbers. What were the reasons?
I didn't ask for reasons why, and what we have not completed yet was breaking this down into, you know, how many urban and how many rural and how they answered, but I think that's going to be, you know, a major difference. Obviously, the folks with limited access are going to be the ones that are more interested in this, and certainly, you know, anecdotally from the people that I've talked to, that's the case. But I have not, we didn't break it down into reason.
Good morning. To follow up on the...
You want to introduce yourself?
Yes, I'm Manish Shah. I'm the program director for the EMSC State Partnership for Texas. Thank you for having me. To follow up on our update, we wanted to give you an update on our evidence summary project that we initiated sometime last year in response to stakeholder feedback for the need for guidance in development of pediatric pre-hospital protocols. To just remind people about the purpose of what we started a year ago, it was to provide summaries of existing evidence to address clinically relevant questions in the management of pediatric patients in the pre-hospital setting so that EMS agencies can consider the evidence to create their own protocols. So just to clarify, the purpose was not to create protocols, but to provide the evidence to the EMS community so that when they're creating their own protocols, they can consider the evidence and also consider the recommendations that we've made. So a little bit about the process. We decided to focus on 4 topics, and the topics were chosen by our advisory committee based on stakeholder feedback that we had received on clinical dilemmas in the pre-hospital setting that they wanted answers and guidance to. And specifically, we did avoid certain topics that we knew were already under development. The National Highway Traffic Safety Administration, the National EMSC program, is about ready to publish a evidence-based guideline for seizure management for children, as well as pain management for all populations. And then as a part of a separate project, we have developed a evidence-based guideline for respiratory distress management that we are implementing. We've already implemented it in Austin. We're implementing it in Houston and Dallas as well, and then we'll be collecting patient-centered outcomes data on that. So we avoided those topics and focused on 4 others. And for each of them, we gathered stakeholder input on what were the clinical questions that were relevant for those topics that they needed guidance on. To do this, we recruited the help of the Texas Children's Hospital Evidence-Based Outcome Center to search the medical literature and to appraise it. And they drafted summaries based on what they had found, and then we made revisions to those summaries and drafted recommendation statements using something called a grade process, grading, recommendations, assessment, development, and evaluation, which has been used for the development of other clinical practice guidelines that have been published in the medical literature. If you're not familiar with it, what GRADE does is it rates the evidence quality into 4 categories that I've noted here: strong, moderate, low, and very low. And then the recommendation that is made incorporates consideration of values and preferences that are either values and preferences from the perspective of the end user or the provider, or values and preferences that may be important to the actual patient. And so those drive the strength of the recommendation being strong or weak, irregardless of what the evidence quality is. So for example, you may have a situation where you have very low quality evidence, but there is potential risk of harm, or there is significant cost implications to a certain recommendation, and so the recommendation may end up being very strong in a situation like that. So we came up with 4 topics, and those topics are cervical spine immobilization, post-resuscitation management, non-transport, and non-traumatic shock management. And so for each of them, I'll show you what the question was and what our recommendation is based on the literature. So the first question for cervical spine immobilization was, for pediatric patients in the pre-hospital setting, what are the specific risk factors for cervical spine injury that can be used to create a selective spinal immobilization protocol? Reason this question came up, I believe, from our stakeholders is this is something that is being done in adults in certain EMS agencies and has been published in the literature, that there are certain criteria that can be applied in the pre-hospital setting by pre-hospital providers to decide who doesn't need to be immobilized. And so what we found, and much of this is emergency department data, and so when the emergency department data is used to apply to a pre-hospital setting, what that does is that downgrades the evidence quality because you're not directly applying it to the patient population that you're considering. So this ended up being moderate quality evidence. And what our recommendation is that when considering the development, if you are going to develop a selective spinal immobilization protocol for children, that anyone who has any of these criteria should definitely be immobilized. They shouldn't fall under selective spinal immobilization because of the risk for a cervical spine injury. And so I've noted them there. And just to clarify, I'm showing you very broad level view of these recommendations. There's a lot of meat to it that I'm not showing you just for the sake of time. What we plan to do with this is we plan to publish the full summary, evidence summary, so that people can actually see what the evidence is and a description of the evidence on our website that explains what these studies are about, what are the potential limitations of the study, et cetera. So it's a moderate quality evidence and a strong recommendation due to the risk of potential harm. For stable, alert, non-cooperative pediatric patients in the pre-hospital setting, do the potential benefits of full spinal immobilization outweigh the potential harm of physiologic or psychological injury? Now, this has come up, especially, we hear this a lot from providers, we hear this from medical directors, that it takes a lot of effort at times to immobilize, especially the very small child who may be fearful. And if they do have a spinal injury, are we causing more harm because they're moving and fighting? And then also in the adult literature, there have been reports of secondary injury that's occurred as a result of traction by placing a spinal immobilization device. And so we thought that this was important for us to address for our stakeholders. So due to the risk of severe secondary injury or death, alternative means to minimize spinal movement during transport or no immobilization at all should be considered when cervical collar placement has the potential to result in more neck movement than no immobilization at all. So the quality of evidence for this is very low, but it's a strong recommendation that it should be considered. So what does alternative immobilization mean? We're leaving that up to the EMS agency, but things that have been employed are the use of transporting them, the child in their car seat with additional padding around their head and neck to limit movement. That's one example that's frequently used already in the field. So granted, the evidence quality for this is low, so does that mean that that you should do this? Well, not necessarily, and I think that's where the strength of GRADE can be highlighted, that a medical director who's coming up with their own protocol can look at this recommendation and say, well, the evidence quality for this is low, so maybe I don't want to incorporate this into my protocol. For pediatric patients with suspected cervical spine injury in the pre-hospital setting, what are the most age-appropriate methods for inline spinal immobilization to minimize harm? So our recommendation, given the anatomic features of a younger child, based on the literature we found, is that children younger than 8 should be transported with elevation of the back or an occipitally recessed backboard to optimize neutral positioning. The goal with spinal immobilization is neutral positioning of the spine. And so because children who are younger, our studies have shown, the low quality evidence that we found show that they're not in a neutral position when they're transported in the standard manner that is applied to older children and adults, that this is our recommendation to optimize neutral positioning. The recommendation is weak. For pediatric trauma patients in the pre-hospital setting, can EMS providers accurately apply criteria for clearing cervical spines in the field? And this gets back to the issue of selective spinal immobilization by the provider. And so implementation of a selective spinal immobilization protocol should apply previously established criteria, such as the criteria that I showed you from question 1, and that should be considered. Now, if a director decides that they don't want to have selective spinal immobilization, that is up to them. But our recommendation is that if you're going to have one, then you should consider established risk criteria that have been shown in the literature. So for non-traumatic shock, I think this one will be less controversial. For the pediatric patient presenting with hypovolemic shock from dehydration in the pre-hospital setting, does rapid delivery of initial fluid boluses improve quality of care? And what we defined as quality of care was decreased intensive care unit stay, admission rate, decreased hospital length of stay, improved mortality, decreased end organ failure. And so for all the questions for this topic, those are the outcomes that we looked at when we did the search for the literature. And I'll say that this was a challenging one to do. There was very low quality evidence. These are things that we do all the time in the hospital. We do them because we know that they work, but it's hard to find evidence that's recent that supports it. So our recommendation is that pediatric patients with non-traumatic hypovolemic shock from dehydration should receive rapid delivery of IV isotonic fluid and alcohol at 20 cc's per kilo. I think if you work in a children's hospital, that's standard practice. I think putting it out there in writing to show that this is a strong recommendation, even though the evidence quality for it is very low, at least gives some guidance to EMS agencies when developing their protocol. Many of them already do this, some may not, and at least then this provides some guidance in terms of how much and when they should do this. And for septic shock, it was the same question, and the recommendation is also the same, with the same evidence quality and the same strength of recommendation. So we didn't find anything different in terms of septic shock management for this. And when it comes to, for the pediatric patient with profound septic or hypovolemic shock in the pre-hospital setting, does a fluid bolus via an IO needle result in improved quality of care relative to deferring IV placement at the receiving hospital? And so the issue is, should you place an IO and give the fluids, or should you just wait and transport them? And so our recommendation is that fluid boluses via the IO route are recommended if administration via the IV route cannot be initiated in a timely manner. And really, again, the evidence quality for this is low, but this is in accordance with American Heart Association recommendations for when to place an IO if indicated. And so although the evidence quality is low, we've made this a strong recommendation. So I think that for the non-traumatic shock, those are less controversial. This post-resuscitation management is something that we were definitely asked by our stakeholders, especially when it comes to the use of therapeutic hypothermia that has been shown in adults to be effective, and I think the verdict is still out for the pediatric population, so our EMS stakeholders wanted some guidance on this. And so the first question, though, that we focused on was, in the post-resuscitation management of the pediatric patient, who has not been previously intubated. How does intubation compare with bag valve mask ventilation in terms of improved outcomes similar to the ones I had mentioned before? And so our recommendation is that in the management of these patients, bag valve mask ventilation is preferred to enhance improved outcomes. Now, the evidence quality for this is very low. It's a weak recommendation, but because there is some data to lean towards to favor bag valve mask ventilation in terms of minimizing harm compared to intubation, our weak recommendation is if you have a choice there, then to go with bag valve mask ventilation. Now, again, values and preferences I think should be considered when applying this. And if you've got a highly skilled crew, if you have a potentially long transport time, then intubation may be the right thing to do. But in most situations, with a short transport time, with the training of most of the providers in our state, bag valve mask ventilation is a recommendation. It's a weak recommendation with very low quality evidence, however. Therapeutic hypothermia, we split this into two age groups because we knew that there was evidence that was different for the neonate compared to the non-neonate. So for the non-neonate, so we call that the infant or the child, does therapeutic hypothermia result in better outcomes? And so currently the evidence, based on the evidence, our recommendation is that therapeutic hypothermia is not recommended in the post-resuscitation management of the non-neonate or child in the pre-hospital setting. There's low quality evidence for this recommendation. It's a strong recommendation. Just as a caveat, there is an ongoing trial that's being conducted nationally. It's the THAPCA trial, Therapeutic Hypothermia After Pediatric Cardiac Arrest. It's a randomized trial that will offer high quality evidence to answer this question. Once that's published, this recommendation may end up changing, but based on the current evidence, our recommendation is that it should not be utilized in the non-neonate. For the neonate, however, there is better evidence, and so our recommendation is that for the neonate, which we're defining as less than a month old, that it is recommended in the pre-hospital setting. This is based on moderate quality evidence, and it's a strong recommendation. And so I know that this is not something that's standardly used in the pre-hospital setting for this population, and so I think that this is something where EMS medical directors could seek the guidance of neonatologists in their area about how to implement this, especially if they're already doing it for adults. And then finally, for post-resuscitation management, does pulse oximetry monitoring with titration of oxygen delivery improve outcomes in the neonatal patient? And so really there was very low quality evidence for this. Our recommendation really came from the American Heart Association guidelines on resuscitation management of the neonate. And so basically using pulse ox to titrate oxygen is not recommended for term infants, but if it's a preterm infant less than 32 weeks of age, that they should gradually have oxygen titrated after delivery in the pre-hospital setting if pulse oximetry is available to guide it. We recognize that pulse oximetry is not standardly available on many BLS units in the state, and so if it's not available, then it's not available and it can't be done. But if it is available, then if you do have a preterm infant, it should be titrated to minimize the harm that's related to high oxygen delivery and free radical formation. So this is a strong recommendation with very low quality evidence. Finally, non-transport. I'd say this is the area where we have probably had the least quality evidence to answer our questions, but it is a topic that our stakeholders wanted some guidance on. And so one of our questions that came up was, does the use of online physician consultation in pre-hospital pediatric non-transport decision improve outcomes? So basically, does calling an online physician improve outcomes when there's an issue of non-transport? This was challenging. There's very low quality evidence, but our recommendation is, since an online physician consultation has some benefit that's been reported in the literature in decreasing inappropriate transports, and there is potential risk of adverse events with non-transport, if there is something potentially wrong with the child, online physician consultation should be sought when making a non-transport decision. This is very low quality evidence behind this, and it's a weak recommendation. Understandably, there, like Tony mentioned, in terms of access to online medical control from a physician, it may not be available. So if it's not available, then this may not be feasible. But when it is available, it should be sought. Our pediatric patients who are non-transported based on decisions made by pre-hospital personnel in the field more likely to experience adverse events. So basically, when the pre-hospital provider decides, yes, this is okay not to transport, are those patients at higher risk for something bad happening? And so our recommendation is that non-transport decisions should be initiated by the parent or guardian of the patient, not the pre-hospital provider. Yet the clinical judgment of the provider should be considered when denying caregiver-initiated requests. So if the parent or guardian says, I don't think this child should go to the hospital, the pre-hospital provider should use their judgment, and if they think that they should, then they should disagree, and they should have that final decision verified, potentially with online medical direction if it's available. And so this is a strong recommendation based on moderate quality evidence. For the pediatric patient in the pre-hospital setting, is there a significant correlation between parental refusal and subsequent diagnosis of abuse? Basically, people wanted to know, for those who refuse transport, are these children more likely to be at risk for some sort of occult abuse that's going on? And this was really hard to find evidence on, and I'd say the evidence quality is low. But and so the recommendation is, since it's unclear if child abuse is associated with caregiver requests for non-transport, pre-hospital providers should not do any supplemental documentation or law enforcement reporting beyond their normal practice. Basically, you should treat it just as any other patient, unless they have some specific suspicion for abuse based on what's going on. But just because the parent said, oh no, I don't want you to take my child to the hospital, that shouldn't raise a red flag based on the evidence we found. And then finally, does the use of online physician consultation significantly reduce the medical and or legal risks associated with non-transport decisions? So does calling a physician help reduce risk for the agency? And again, this one was hard in terms of finding evidence, and I think the answer is unclear. However, pre-hospital providers should document who initiated the non-transport, who approved it in the medical record, and they should consider online consultation to minimize medico-legal risk when it is available. So those are our recommendations. I know some of those are very standard things that are commonly done, and some of those might be somewhat controversial, so I welcome your questions.
We've actually apportioned 10 minutes for questions, so please.
In your shock protocol questions, did you distinguish cardiogenic shock from in that group? Because 20 cc's per kilo in a heart patient that's pediatric base is different.
Yes, that's a good point. So no, we didn't distinguish just because we thought that in searching the literature, finding things for cardiogenic shock would be few and far between. So I think that's an important caveat that we probably need to add to the recommendation, that if there's suspected cardiogenic shock, that number should be decreased to a lower amount. That's a good point.
And then when you compared the BVM versus endotracheal intubation, is there wording in there versus other modalities like LMA and things like that?
So we didn't look at supraglottic devices, no, like LMA or King Tube or things like that. That was one of the questions that we had available that we had people rank, and it didn't end up in the top 3 or 4. I will say that just having looked at that question, there's very little evidence for the use of supraglottic devices in the pre-hospital setting in children. Most of the evidence that's out there is in simulated situations, and so I think that question would be difficult to answer. Yeah.
So I have 2 questions for you. This is awesome work and very long overdue. First, how are you going to disseminate the information to EMS providers? Mm-hmm. And then what's next on your list to start working on?
Sure. So great questions, and thank you. We plan to disseminate this online through our statewide EMSC website, and we have a list of stakeholders that are on our statewide listserv. And so once we have the website that up and live, which we plan to have sometime in the next year, we'll make that known to our stakeholders, and we'll also report it to the Medical Directors Committee of GETAC and seek their endorsement of it. In terms of future planning, we do have plans in the future to continue this process. This is quite a time-consuming process, just like what Dr. Macias was saying about developing guidelines for one thing, like, the Image Gently initiative. Developing guidelines for this, it is quite time consuming, and it requires supplemental funding. So we have set a goal to do one topic a year over the next 4 years as a program. If we have additional funding or resources, we can expand that, but we've at least set a goal to do one topic a year over the next 4 years.
So, question
Yeah,
for
and in terms of which topics, we haven't defined that, and we definitely want to seek stakeholder input on the actual topics. Yeah.
The medical directors committee also talked about they're going to have a website on the DSH
Yes.
Yes.
website, and we talked about putting a link. We talked about putting a link on their website to these this evidence.
Absolutely. And then the other thing in terms of dissemination is we're seeking to add a representative from TCEP, Texas College of Emergency Physicians, on our advisory committee, and potentially someone who's very active in the EMS community in the state. And so being able to disseminate it that way as well, I think, will be another avenue. And then also through contacts with people who attend the Eagles Conference for EMS medical directors, because we don't want to necessarily restrict it to just our state. People all over the country could use it potentially.
So one conceptual thing, you've gone very quickly through the development of evidence summaries, and so in the process of what this whole genre of translating evidence into care, knowledge translation, what that engenders is an understanding that what gets filtered from an evidence summary to an actual protocol is all filtered through values and preferences.
Yes.
Can you make a comment about how values and preferences are stated so that something written here may not be exactly what gets taken back into the communities?
Sure. So, for example, if you're a medical director for a rural agency, then one of your values may be to enhance, to minimize on-scene time so that you can get the patient transported to the definitive care in a timely manner. And so considering that value as a medical director, then if you look at the recommendation, certain things that might cause more on-scene time, you may decide, well, if that's a recommendation, that's a weak recommendation, maybe I'm not going to incorporate that into my algorithm. Or another could be consideration of the skill level of my provider. So, for example, if I operate a flight EMS agency that all they do is air transport, and that all my providers are seasoned flight paramedics or nurses who have quite a bit of intubation experience, that recommendation about back valve mask versus intubation, they may decide, you know what, I know my providers, I know their skill level, and since that's a weak recommendation, I may decide that for the safety of the patient and being able to reassess them, that intubation might be the safer thing for my patient. So that's where you consider values and preferences. They're not hard and fast recommendations. You have to look at the strength, the weak versus the strong, and then you have to consider who are my patients, what are the constraints and the resources I have, not only of the patient population that this is going to affect, but also the people who are going to implement it at the ground level. Yeah.
And it should be explicitly stated in that protocol so that that becomes your own standard and it's clear to people why it deviates from others.
That's a great way to be prescriptive without being demanding.
Absolutely.
It makes so much sense.
Well, it's about the highest quality of care because it's really tailored to your own infrastructure.
And is there a post-implementation metric that you're going to use? You're going to follow up with your stakeholders to see what kind of grab you've gotten with these recommendations? Because what I'm fearful is we make recommendations, it's out there, everybody likes having them, but they don't implement anything.
Yeah.
So is there a way to monitor what kind of seepage you get into with the medical directors?
Yeah, that's a great question. So we have planned that for the respiratory distress protocol. So what we plan to do with that one in particular is when we're and we're working with our information services folks to have it so that when somebody logs on, somebody accesses the website, they have to log on and put in their name and their email address, so that after the fact, I can contact them and find out, okay, you viewed the respiratory distress protocol, what did you do with it, with that information? So I've planned in advance to do that for respiratory distress. We haven't planned to do that, but that one's an actual full algorithm. It's laid out like an algorithm. It's not just a summary of evidence. That's a full protocol. So, so that one we are going to do that. We hadn't planned it for this. We could design something for that, but in terms of what is in the plans already, we're doing that. We're going to do that for respiratory distress.
And
after it's been fully implemented,
Right.
it's been implemented in Austin this month. Houston starts in November. Dallas will start in February. So once the implementation starts in Dallas and the sites are using it, then we'll make it publicly accessible.
And as the evidence changed, what's your cycle for review of this information?
That's a great question as well. So anytime you make an evidence-based recommendation, because there's always new evidence that comes up, they have to be periodically updated. And so our plan for these is to update them on an every 2-year cycle. We've also, just looking at the model of in-hospital use, that's also a similar model that we used in the hospital. So yeah, they do have to be periodically updated. Probably every few years, and we've considered doing that every 2 years.
I was just going to add the comment to your question about following up, finding out how they're using it. By our grant, we're going to be doing surveys for EMS agencies every 2 years, and that's something that we can build into that survey, I think, and really get some good data on that in the future.
Thank you.
Great. Any more questions? All right, very nice work. All right, so we actually had apportioned 10 minutes for questions for each of the 3 segments, which were the radiation exposure minimization, the online survey, and the protocols. We used only 10 minutes of the protocol questions, which means we are right on target, and we are going to be done almost 20 minutes early. Just want to review a summary of our charges. We have for tomorrow's presentation the finalized version of our policy, of our position statement for minimizing ionizing radiation, and that is voted for endorsement. We will then take in our November 2012 meeting the creation of a matrix for society partners and tools suggested for an implementation bundle for that project to coincide hopefully with a number of activities that the radiologic societies and the American Academy of Pediatrics are rolling out in 2013. For the state partnership, we will include our traditional report and no specific charges to that, and we will add back our child fatality review report. In the February 2013 meeting, we should also have discussion which will tie all of these segments together, the 3 critical things that you heard about on quality improvement for the pediatric readiness project, which will make, I think, all of these independent quality improvement initiatives much more cohesive. So that being said, open this up for any public comment for anything that we have not yet discussed.
Good almost afternoon. My name is Christine Reeves, and I'm the Executive Director for Heart of Texas RAC out of Waco. And I'm a tad bit concerned that in the discussions about dissemination of this information, the protocols, nobody's mentioned the RACs. And many of us have our pediatric committees, and we have regional guidelines for EMS protocols. So I would say that please remember your RACs are always there, and we're probably your easiest contacts to your pre-hospital providers and to your facilities. So we take this information back, but to get the specific recommendations, I think you would do a disservice to the pediatric community if you didn't include us.
And the invitation is both for the decreasing ionizing radiation project as well as the
Absolutely.
protocols you just heard.
Yeah, anything that needs to be implemented.
Be careful what you ask for.
Well, we get tasked with stuff anyway, so it doesn't, I mean, our hospitals and EMS providers are used to getting information from us, and so passing along information is what we do, what we're that's just what we do.
No, it's an excellent point, and we definitely appreciate the opportunity.
Thank you.
We'll take you up on that. Any other public comments?
Hi, I'm Dr. Moore from Tyler, and I just have a question. I'm on my hospital's ionizing radiation committee, and we look at a lot of these issues, but is anybody comparing injury severity scores and the use of radiation by score? Or is there any possibility of maybe as hospitals are reevaluated in their ongoing recycling of approval as trauma centers at each level, to ask for that amount of radiation by age, by injury severity score, to see if there is a lot of variation or if we're all very consistent at each level? I mean, we talk about it a lot, but is anybody using that as a criteria for quality review of that particular hospital?
I don't know if anybody's doing that kind of post hoc analysis. I could certainly forward that question to the National Image Gently people. I'm not aware of anything published in that manner, and I think part of the reason for that is much of the science of clinical decision rules has really focused on minimizing radiation through the development of targeted areas. So the answer to your question would be yes, if you drill down to what are the risk factors associated with severity from a closed head injury. So not using the generalized score, but using the risk factors associated with closed head injuries, appendicitis, blunt trauma, and I think those are the most comprehensive rules defined. So within those three disease processes, absolutely. Generally, I don't think so.
Yeah, do we even know if the CT scanners at some of the levels 3s and 4s are capable of doing the low dose?
We don't know that, and that was one of the things that we had discussed in our prior meetings.
Should they not be maybe encouraged to not do the CAT scan, but just transfer the patient to the hospital that has the low dose capacity?
So I think what will end up happening, and this is true of on a national level as well as what we are doing in the state, is that a lot of these capabilities or lack of capabilities will become transparent, and the best quality solutions will be tied back to the outcome. So does it matter if I'm Texas Children's Hospital and you're 20 miles away from me and you don't have the capability to do any neurosurgical intervention? Does it matter whether you know based on clinical symptoms? The answer is probably no. It's probably better you just get them to us.
If you have a scanner that can do the low dose.
Right, exactly.
radiation.
Exactly, and can actually respond to the information found. So one of the in the world of quality improvement with improving diagnostic accuracy, one of the questions that we ask in the world of testing is the likelihood ratio one in which we're going to do anything about it? If you don't have the capabilities to do it, then it sort of refers back to what you're asking.
We have a level 1 trauma center, and I don't even know that anybody's asking the trauma surgeons, why do you keep so many routine CTs as part of your trauma protocol? Is there evidence based that that's going to help the patients, or are we really just over-ionizing a lot of patients because of those protocols?
Well, and I think that is, there's certainly evidence that, especially with abdominal trauma, that targeted areas seem to be the best approach, and part of the reason that one of our specific recommendations is to avoid sort of mass radiation, mass protocols.
And then you just have to realize that the standards by which the evaluations takes place comes from ATLS, and ATLS is to evaluate the entire patient, and that's where the protocols get disseminated from adult-based situations. So there's nothing specific from pediatrics. You have to combat ATLS for pediatrics. And then speaking to kind of urban or rural versus rural CT scanners, There's a national trend for kind of the manufacturers of CT scanners to have pediatric dosing on all scanners. However, the evolution and the time which it takes to change out, you're not going to have the funding now. It's going to take several years for you to come up on your next budgetary cycle for CT scanners. So we will have a transition period for the next, I'd say, 5 to 10 years before you can have a pediatric dose CT scanner in every situation.
Right, because I know that a lot of the CAT scanners in the 3s and 4s are hand-me-downs from the levels 1s and 2s. And so as they transition to the right kind of scanners at the levels 1s and 2s, you're still going to have the 3s and 4s for years using scanners that are putting out too much radiation.
Certainly.
So, but maybe if we had that as a quality review issue for all hospitals, 3s and 4s in particular, they would start saying, well, we really shouldn't do that CAT scan because it is over-ionizing our kids.
No, it's a point well taken, and I think that will become even more relevant as we move into the next phases of looking at strategies for implementation and providing tools to our institutions, and then linking this back to our pediatric readiness, because as we mentioned earlier, this is a pediatric-specific issue.
Right.
So,
Thank you.
all right, and thank you for your comments.
Should we make a comment about the survey or the assessment that's going to come out in January?
Do you want to talk about it?
Yeah, one of the things that Dr. Macias mentioned was the pediatric readiness assessment. What's it called, Tony? National Pediatric Readiness Project. Texas is going to be in the first wave of states that does the assessment. Those will be coming out in January. So if you're a trauma coordinator or an ED leader, manager, whether it's medical director or nurse leader, you will hear about that assessment. We're not supposed to call it a survey anymore. But it's a QI project, PI project, where you will assess your emergency department's readiness based on the guidelines for care of children in the emergency department, which was a joint policy statement in 2009 from AAP, ASAP, and ENA. And you will take the checklist and go to your supply closet and go, yep, we got that, we got that, we got that, and then you will input that data into the computer, and it will automatically give you a readiness score. So the goal is for all hospitals to have at least an 80% readiness score, and those assessments will be coming out in Texas in January, so please be looking for that. Hopefully the hospital CEOs will also get a letter and be committed to making sure that gets done. It'll take you about 45 minutes to an hour to do it. You can print it out and, like I said, take the checklist to your closet and see what equipment you have. So anything else you want to say about that, Tony?
Since you brought it up.
Yeah.
We're going to talk a lot about this in our next GETAC meetings, but the NPRP program, what I want people to understand is that we in Texas, we're taking this much beyond just a survey and just a self-evaluation. We have sought and got endorsements from the Texas ENA, from THA, from CHAT, and from TPS to build this into a quality improvement program. What kind of quality improvement program is going to depend a lot on stakeholder feedback and communication that we're going to be really kicking off in September to kind of get an idea of what folks might want and need, and to really explain what this is all about. I can tell you that this program is, on a national basis. It's been piloted in California. They had a great response rate. They put a lot into it, and we're learning a lot about what they can do with it on a long-term quality improvement basis from their program. But it has a lot of potential here in Texas to help us out with a lot of issues, and a lot of issues that really cut across a lot of the things that we've talked about today. The position statement that you're just talking about, that can certainly be infused in any kind of a quality improvement program or a toolkit that we put out there. Our community and critical access hospitals out there, not only do they have the right, equipment available, but are they, prepared for that pandemic and disaster? Are they You know, are they tied into medical homes in their region, or do they know how to, you know, get access to that, so forth and so on. And even to a point, you know, that do they have a policy or procedure or, you know, something in place so that when their local EMS calls in to that hospital, because that's what they do, is there somebody going to be there to answer the phone and give them advice? And so all of those can be tied together. And by the way, your comment on the racks, if you're out there, please go back to your racks. That's something that we can work on immediately. Encourage your hospitals to make sure that they've got folks answering the phones when your EMS calls in.
All right, thank you. All right, with that being said, this meeting is adjourned.